Patients often come to me with a patent foramen ovale or PFO and a prior stroke, wondering whether PFO closure is necessary. And often these patients have received differing advice from different practitioners. And so I think it's important to understand where the data sits and what do we know about the benefits of PFO closure and for whom this may be an appropriate procedure. I think this is especially germane in light of the recent FDA approval of the Amplatzer PFO closure device as indicated for patients with cryptogenic stroke to reduce the risk of recurrent stroke. We know from autopsy studies done a number of years ago that PFO is extremely common. Between 20 and 40% of patients do have a PFO, and we're certainly not rushing to close all of these PFOs. So how can we understand for whom it may be an appropriate intervention? Well, the bottom line is that all patients that come with a stroke should have a thorough stroke evaluation. And that consists of history, physical examination, echocardiography to evaluate for structural cardiac disease. It consists of brain imaging with MRIs and ultrasounds to understand whether cerebrovascular disease is an issue. It consists of evaluation for hypercoagulable disorders, an understanding of whether arch atheroma may be a causative agent in a patient's stroke. And I think one very important consideration is the risk of cardiac arrhythmia and especially atrial fibrillation. We do know from a couple of very well done studies that in patients who have only 24 hours of cardiac rhythm monitoring in the setting of a stroke, then only about 2.2% of patients may manifest paroxysmal atrial fibrillation. Whereas when these same patients are followed out with a telemetry monitor for up to 4 weeks, then almost 15% of patients may manifest paroxysms of AFib. And given the risk factors, these are patients who would benefit from anticoagulation, and so whether or not they have a PFO may in fact be truly irrelevant. Ultimately, in those patients who without a typical cause of stroke and so who do truly have a cryptogenic stroke, there may be a role for PFO closure. Our group looked at a meta-analysis about 4 years ago that was published in the Journal of the American College of Cardiology about whether PFO closure with transcatheter devices may be beneficial compared to medical therapy alone. And what you can see here is a significant, almost 75% relative risk reduction in those patients who underwent transcatheter closure. Now, of course, we do like to base all of our medical therapies on randomized trials, and so with the limitation that this is a meta-analysis, I do think it does provide us some important information or at least important signals. The other thing that I would point out from our analysis is that percutaneous closure of PFO is a relatively safe intervention, again, in appropriately selected patients. And the one thing I would point out specifically is that the risk of atrial fibrillation is just around 1% in these patients who have undergone a closure. Again, whether in these trials it was the result of atrial fibrillation that was not found previously or atrial fibrillation that occurred after the closure is of course difficult to say, but this is an important number to keep in mind. And with that background, if we then move into what I think are the two most contemporary PFO closure trials with differing results, I think it helps us to understand why there's a controversy and whether PFO closure is beneficial. This was a closure trial that was published in the New England Journal of Medicine a few years ago. It enrolled just over 900 patients with a stroke or TIA who underwent closure with the NMT StarFlex device. And what you can see here is that there was no statistically significant difference between those patients who had closure or those who continued medical therapy. And this was reflected in the conclusions of the New England Journal, which stated that in patients with cryptogenic stroke or TIA who had a patent foramen ovale, closure with a device did not offer a greater benefit than medical therapy alone for the prevention of recurrent stroke or TIA. Now, if we keep that in mind and then move towards the RESPECT trial that was published about 3 years ago, also in the New England Journal of Medicine, this was a trial of 980 patients who had only a stroke, not TIA, only stroke, who either underwent treatment with the Amplatzer closure device or medical therapy alone, consisting of either antiplatelet or anticoagulant therapies. And what you see here is a 51% relative risk reduction in the intention to treat analysis. However, that did not reach statistical significance. Now, the important thing to keep in mind is that this was the intention to treat analysis. And of the device group, 9 patients suffered a recurrent neurologic event. However, if we look at the as-treated analysis, in fact, there were only 5 in the device group that had suffered an event and received a device. So the other patients actually had not received a device. And in this analysis, the as-treated analysis, there was a 73% relative risk reduction in recurrent neurologic events. And you see that this did, in fact, reach statistical significance. And so as reflected in the conclusions of the New England Journal paper, you see that in the primary intention to treat analysis, there's no significant benefit associated with closure of the PFO. However, closure was superior to medical therapy alone in the pre-specified per protocol and as treated analyses with a low rate of associated risks. So how can we understand side by side the results of closure, which didn't show a benefit, and RESPECT, which may have shown a benefit? Well, closure enrolled TIA and stroke, whereas RESPECT enrolled stroke only. And I think we all know from clinical practice that sometimes diagnosing a TIA can be very complicated. And maybe it's truly a TIA, maybe it's a migraine with aura, maybe it's another syndrome altogether. It's tough to tell. So RESPECT was a lot more stringent in their enrollment criteria, which I think is important when we're looking at neurologic outcomes. The closure trial used the StarFlex device, which is a device that actually is no longer available. It's no longer sold because of complications associated with the device. The RESPECT trial used the Amplatzer device, which in fact is a device that was recently approved for this indication by the FDA. Effective closure was achieved in about 86.7% of patients in the closure trial, whereas effective closure was achieved in a much greater number of patients in the RESPECT trial. I pointed out to you earlier in our meta-analysis the risk of atrial fibrillation is around 1% in PFO closure trials, whereas in this closure trial, the device arm noted atrial fibrillation in just under 6% of patients. And again, in clinical practice, we know that is an important risk for future stroke. In the RESPECT trial, in the device arm, only 0.2% of patients demonstrated atrial fibrillation after closure. Furthermore, the mean follow-up in the closure trial was just about 2 years, and that was a maximum follow-up. In the RESPECT trial, whereas the mean follow-up was 2.6 years, there was follow-up up to 8.1 years. So especially in a situation where we're looking for a low rate of events, longer-term follow-up is going to be important. And this really brings us then to the most recent publication of results, or presentation of results, I should say, from the RESPECT trial, which is their long-term data falling out to about 10 years, that was presented just last week at the Transcatheter Cardiovascular Therapeutics meeting in Washington, D.C. And what they did was, following out now to 10 years, that same group of patients in the RESPECT trial, what they demonstrated in the intention to treat analysis was, in fact, in the device arm here with PFO closure, a substantial 45% relative risk reduction in recurrent neurologic events compared to the yellow line here of medical management alone. And at this point now, this does reach statistical significance. And if we look, of course, at those patients with an unknown mechanism after PFO closure who suffered a stroke, so not the patients who had closure and then had a stroke attributable to atrial fibrillation or some other very clear etiology, we see that in fact the relative risk reduction for cryptogenic stroke at that time is up to 62% with device closure, again, which was statistically significant. So if we then take the bottom line of PFO closure and stroke, it's true, not all patients with a PFO require closure. Stroke as a result of PFO is ultimately still uncommon. And it's most important to have a thorough analysis of potential stroke risk factors prior to embarking on PFO closure. The lack of typical stroke factors may make the association between PFO and stroke more likely for a given patient. Certain anatomic features of the PFO that we assess based on transesophageal echo, such as the size of the PFO, the degree of shunting, whether there's spontaneous right to left color flow across the PFO, these may be more risky factors for a given patient and may prompt us to consider closure more strongly. The RESPECT trial did demonstrate a reduction in recurrent stroke among carefully selected patients with a PFO. I think it's important that these were very strict inclusion criteria for this trial, the use of a contemporary and safe device, and I think that is why, in comparison to prior trials, the RESPECT trial did show a benefit in this very controversial situation. And ultimately, if appropriate, I think closure can be conducted with a high degree of safety and efficacy to reduce stroke for patients with a prior stroke. And so I think ultimately this can be a very important intervention for some of our patients. At the Cleveland Clinic, this is something we've been looking at for a number of years. I showed you the paper that we published a few years ago with this in mind. But I think the most important thing about the RESPECT trial is that this is truly a randomized trial. It's not a meta-analysis. As I said, it's done with a quality device in a quality trial. And so I think if nothing else, it really informs us most significantly that we can help our patients who have a PFO, again, when they're carefully selected. And I think that this trial, my hope is that it will help to shade a lot of the controversy that surrounded PFO closure for patients with recurrent stroke.